Okay, so let's get started on our STD lecture. One of my favorites, obviously. Display is on. So, talking about sexually transmitted diseases, this is a really good topic to start right after male reproductive and female reproductive. So, one of the things that is a little bit different for this particular content is HIV will not be covered. Another one they took away from me that I really like to cover because it's a really fascinating disorder that really, well, we just covered immunity and all the components related to that. So knowing how that virus attacks our CD4s is very interesting. But anyways, they get to do that in third because that's in third you're going to be covering chronic diseases. Okay. Definition. Infectious diseases associated with intimate sexual contact. It is still called STDs by the CDC, and that's who is my god as far as infectious diseases. STIs is what you'll see in IGGI. So don't be surprised it goes back and forth. But I think right now we're pretty solid on STDs as being the word that's being used the most, sexually transmitted diseases. There are about 17 billion $17 billion per year, 19 million new cases a year in the U.S. alone. And the information that I'm going to be sharing with you, really the only information that's being collected is on gonorrhea, chlamydia, and syphilis. There's a lot of other ones. So these are the ones that we actually are following, and they have studies that come out on a periodic fashion talking about it. There is no info on HPV. There's no info on genital herpes. Many cases go unreported and undiagnosed. Even despite that, there are now resistant strains occurring. We'll talk about some of those. There is, of course, once you get an STD, there is an increased risk for resistant strains. And there is also an increased risk for HIV. Once you have one STD, the risk of getting then HIV is increased, as well as getting any of the infections that can then cause other problems. Untreated, an STD untreated can cause sterility and harm to the unborn child. Right now I'm kind of talking about STDs in a very general format. And then we'll talk about the specific ones. So untreated, it can cause sterility and harm to your unborn child. Actually, they say that in a pregnancy with untreated syphilis, 40% of them will end up with some kind of birth defect or stillbirth. So big risks here. Herpes and HIV are two of the STDs that are incurable, and they're going to be lifelong infections. And with women, with women, it could cause severe health problems, cervical cancer being one of the #1 problems. So we look at pelvic inflammatory disease, PID. We'll talk specifically about that. Ectopic pregnancy is another one. And infertility is another problem for females predominantly. 24,000 women per year if they're untreated. So you know I'm not going to test you on any of the numbers. You just need to realize that having an STD is going to increase your risk for all these things. Contributing factors. I didn't think I had a cold. Contributing factors. Some of the things that have caused more STDs. I mean, when I was in nursing school, the only STD that we worried about was gonorrhea. And Dr. Moe, who's probably long dead now, would give a shot of penicillin. We weren't very worried about STDs. Okay. And that was in the 70s, and yes, everyone was very sexually active, still are, but that was definitely when things were really changing as far as birth control being easily available and different attitudes about sexual behavior. So the only one we worried about was that. Yeah, syphilis could happen, but it wasn't quite as predominant. It was gonorrhea was the only one. Now we have a whole bunch, and we'll talk about that. So, contributing factors to the increase in sexual transmitted diseases, longer sexual lifespan. I remember if I saw a patient over 60, that was pretty amazing. When I first came into nursing school. So the lifespan has really increased. Early reproductive maturity is also contributed to it, as well as our increased longevity. There is greater sexual freedom and leisure time in our communities. And now we're having a problem with an increased incidence with elderly, because now that we have the erectile dysfunction meds that can help elderly men be able to continue their sexual life, we are now seeing problems with the elderly population having STDs and a lack of information. Part of the problem, and we're talking, let's say, over 60. So these people are being involved in sexual activity perhaps they wouldn't have been in the past because they weren't able to maintain an erect penis. So now with Cialis and Viagra, we can. Now they forget. They think to themselves, oh, I can't get pregnant because I'm past menopause, but they forget they can get STDs. So that's something that we have to really educate our growing elderly population. They're not using condoms because they aren't worried about pregnancy, but they still need to use condoms because of STDs. We also have other contributing factors. Drug abuse also will cause a incidence of STDs. There's no doubt that when drugs are being used, or alcohol, or any mind-altering, that we aren't as responsible as we should be. And then, of course, contraception is another one that has helped to make us have us be more sexually active and less worried about pregnancy. But now we need to worry about STDs. Incidence. Well, it says here that half of all sexually active people will get an STD by the age of 25. So if we have a group here of 18, 9 of you would have an STD by the time you got 25. That's the reality, okay? The greatest risk is to our Black and Latino populations, according to CDC, and especially our adolescent females from the ages of 14 to 19. We see in that general group 24% incidence, and with the Black female young population, we have a 48%. Men having sex with men, MSM, their highest risk is with the syphilis and HIV, but they're also a group that is a higher incidence of STDs. Okay, so let's talk about how can we prevent STDs in general, then we'll talk about specific diseases. The change of lifestyle contributes to a high risk. So these are lifestyles patterns that will increase a person's risk of getting an STD. So one of the high-risk behaviors is having multiple partners. Another risk behavior is not practicing any kind of prevention, and we're talking about condoms. Of course, any person that's needle sharing increases your risk, certainly for, not for all the STDs, but certainly for our HIV and hepatitis B. And then, of course, any kind of alcohol, drug, or substance abuse will also put you at high risk. How can you protect yourself? Well, safe sex practice is number one. Abstinence is recommended, and if certainly this is the foolproof method to prevent STDs is abstinence. But we also are realistic in our society and know that when we're talking to young adolescents, that that may not be an option. The other one that they would recommend is mutual monogamy. The use of condoms is absolutely encouraged. Remember, it should be latex or polyurethane. Some people have used lambskin. I mean, you know, as we go through, our society has some people very vegan and don't want to use anything that's not natural. They want to stay very natural. But the problem with the lambskin is it actually will prevent pregnancy, but it won't prevent STDs because the diameter of the pores is big enough so that the STD infection, some of them can get through. Another thing that some people don't remember is that oil-based lubricants can damage a condom, so it should only be water-based. So should avoid baby oil, Vaseline, and massage oils because those are all oil-based. So so if you look at KY jelly, that's a water-based, so that one works. And of course the percentages of breakage on condom is 2 per 100. That's why you get a 98% success rate with condoms. Okay. Speaking of condoms, when I was a school nurse, we got this from, I can't remember who gave this to us, but I really liked it and kept it, obviously. But it teaches your students how to put a condom on properly, you know. So if you flip it from the back, you'll see it do that. I like this. Don't anyone steal it from me. Okay. And so we would have those around, making sure, you know, and this is the thing about when we talk about, I don't know so much about female reproductive, because women, we tend to talk about things, but male reproductive and certainly STDs are areas that people don't really want to talk about them, so you kind of just have to talk about it, especially with our teenagers. Okay, remember when we talk about spermicide, vaginal spermicides, very effective for trying to help prevent pregnancies, but it is very ineffective for our STDs because it disrupts the epithelial layer, and anything that is going to injure or harm our epithelial layer is going to give us then an opportunity for an infection to come in. Okay. Of course, birth control pills, great for pregnancy, not effective for STDs. That should be obvious, but it's amazing when you start talking to people how they've taken information from various different sources, some of them unreliable, and then they don't really have accurate information and they make some assumptions based on inaccurate information. So don't ever assume that they know. An IUD, real effective for preventing pregnancy, but certainly will not provide protection against STDs. And remember, females are definitely the ones that are more at risk for STDs than males. Males, typically, when they have a sign and symptom of an STD, it's real obvious. Females, no. The lesions will not necessarily show, will not show. They're usually inside us, and so we can't tell. So that puts us at risk for not seeing the situation until it becomes a real problem. And then, of course, other ways that we can protect ourselves is vaccines. There are certain pre-exposure vaccines. HPV is one, as well as hepatitis B. We're not really going to be talking about hepatitis B here. It's really more of a blood-borne transmission, but you will talk about it next semester when you talk about liver problems. Okay. So these are the ways that we can protect ourselves. Some kind of safe sex practice, whether it be abstinence, condoms, one partner. We know that spermicides, birth control pills, IUDs are not going to help us, right? So don't rely on them. And vaccines are a very good one for our HPV. All right. What are the general symptoms of an STD? So I'm going to start off with the first thing is that most of the time there are no symptoms. And that's why this is a difficult one to get a diagnosis early on. So, but some of the ones that we do have is discharge, burning sensation, sores, lumps, bumps, itching, abdominal pain, lymph node enlargement. All these could show in our patients. But like I said, most of the time there are no symptoms. Transmission is through some kind of direct sexual contact usually, either oral, anal, or vaginal sex. There has to be some kind of contact with vaginal fluids or semen or some kind of discharge for the disease to be transmitted. Through fluids, the ones of the STDs that are transmitted that way through sexual fluids is the HIV and Chlamydia and GC are the ones transmitted that way. Blood, the ones that are transmitted that way are HIV and hepatitis B. Skin to skin, this is the ones that you should be worried about because this doesn't mean you have to have sexual contact really, but skin to skin, usually some kind of genital skin to skin, but not necessarily, is our herpes and our syphilis and our HPV. And when we talk about these specifically, we'll talk about what stages the skin to skin is a risk even for us as nurses. And then of course several of these different ones are risk to the unborn child. And we'll talk about those as well. Labs, that's on the next page. Labs, we want to get specimens related to that STD. So depending on what the STD is, will depend on what kind of specimen we're going to get. It's not uncommon for us to get some kind of lesion scraping. And of course, UA is one that we look at to see if there's any urinary tract infection going on. We'll do usually a CBC to see if our WBCs are elevated. And then, of course, another test that we want to consider is the pregnancy test, because certainly if our female patient has an STD and they are also pregnant, we need to treat it in a different perspective, looking for the unborn child risk. Treatment? Okay. So the important thing about once a patient, as a practitioner, we realize our patient has an STD, is to get treatment immediately. What we need to do that's different from many of the things that we've talked about this semester is this patient needs to get treatment for himself or herself, but also needs to get treatment for their partner or partners. So it's a little bit different animal, isn't it, here? So I did list here the STD National Hotline. This is a great way for people to get information anonymously and be able to talk to someone that is up to date on all their information. So this is a great hotline to use. The CDC website is also another really great location to go to get current information. They actually just have like fact sheets that you can print off and get the information on what you need to do. But you'll really find that the best places to go for information are not our books, but are in the clinics. Vista Community Clinic, North County Health Services, these are clinics in our area that really are up to date on what is the current treatment that should be done for each of these and what risk factors. And that would be the preferred place, I would say, to go than any other place. Okay, so we talk about them that they need to get the treatment, so they need to complete the prescribed treatment. Because this is a high risk for reoccurrence, okay? So they have that risk of the infection continuing, the reoccurring, but they also have that risk for what happens once you take antibiotics and the next time you take them, we could be resistant to them. So we don't want to create any of those sorts of situations. And then, of course, we want this patient to always come back for a follow-up appointment. This is that patient that we need to get back in to make sure that they are completely clear. Okay? They need to be abstinence. Okay, I think this is on my next slide. Yeah, they need to practice abstinence until they are completely cured. And of course, this is the patient that we would talk to about getting some kind of vaccine to prevent any reoccurrence. Some of the things that we look at is the screening recommendations that come out periodically. The last one we have is 2010. And this is the screening recommendations that they ask for us to encourage our patients to do. For women under the age of 25, how many do I have women under the age of 25 in this group? Only one? Two, okay. This is what you should be doing. Annually, you should be being checked for chlamydia and gonorrhea. Well, let's say to all the females, how many of us ever did that when we were under the age of 25? If you're sexually active, you should be, okay? For our men having sex with men, MSM, we want to encourage them to go into the doctor to see them annually, and they are going to be screened annually for chlamydia, gonorrhea, and syphilis. And of course, right now, we have a 50% compliance rate on this. So less than half who should be screened are being screened. So that's not surprising. I'm surprised we even made 50%. Okay, next one is, what about nursing care? What should we do for all of our patients with STD? Yes?
Aren't certain STDs reportable to the public health department?
They are, and we'll talk about when we go through each individual one. But the only ones that are reportable is what I said at the beginning, the gonorrhea, chlamydia, and syphilis. Those are the only ones that are being reported. So when we get information, we need to remember that one of the most common ones that we have out there right now, HPV, is not even being reported. So we'll talk about that when we get to HPV. So nursing care, well, first off, we need to identify our patients, right? So we need to look at some of the things that we need to do a risk assessment. So when we have a patient that has multiple partners, they have a history of past STDs, we call them the 5 Ps. Multiple partners, past STDs, they're not practicing any kind of prevention, they aren't even preventing pregnancy, and they are engaging in risky behaviors or practices such as drug abuse or alcohol, then these patients are going to be patients that we're going to identify as being at higher risk for STDs. Remember, again, we just talked about this, reportable to the public health. We have to report chlamydia, gonorrhea, syphilis. Management, nursing care for management. One of the main things is that we need to maintain confidentiality for these patients. There is a fear of telling their partner. But if they don't tell their partner, then we know that the risk of reoccurring infection for themselves is there, not to mention the spread of the infection is there. So, as a result of that, they have developed the expedited partner therapy. And what this is this is actually legislation that has occurred in about 30 states, California included, where I could go in, let's say I go in and I say I have gonorrhea. My husband won't come in. I'd drag him in, but he doesn't want to come in. I can get treatment for myself as well as treatment for my spouse and take it back to him, and he can then treat himself at home. Huge amount of problems that we can see occurring here, can't we? Huge amount of problems if we don't treat that spouse, though, too, okay? So the partner won't come in, so they have had this way so that we can treat. Now, I could see this being really abused. You know, I could see where I would say to my husband, oh, I have strep infection and you need to take this, and give it to him every day because I don't want him to know I have something else. I could see it being abused, you know. But I also see that if we need to give options for people to be able to treat their partners confidentially. There's been a lot of risks with this one. One of the biggest risks that if I'm the practitioner that's giving this prescription to my patient who I am seeing, but giving a prescription to a patient I am not seeing, that's a whole nother game, you know. But the CDC does recommend this EPT program. And like I said, California does do this as well as 30 other states. Let's see, what else? Okay, so I'm talking about nursing care. We do have that option. One of the things that we do want to do is, of course, as nurses, prevent reinfection in the untreated partners. So we want to make sure that not only is our patient that's coming in being treated fully, but the partners are being treated fully and completely, and making sure that there's follow-up. Patient education is certainly important. We need to give them informed, accurate, current information, and current information is a hard thing to come by. CDC does keep their website up pretty currently, but if you look at Iggy just can't stay current. I mean, how many years ago did she write this? And you figure by the time it went to print and all that and gotten to you guys, we lose a lot of the current information. The people that are really current are the people in the military clinics and the community clinics. Those are the people that are really current on what is the new practices and what is coming up. So let's look at some of the different diseases specifically. Gonorrhea. Now, the threat level for this one is urgent, which is not good. In the past, it's been historically low levels, but right now we're getting signs that there is a gonorrhea coming through that is resistant to treatment. In fact, we have one that's out there that's resistant to any antibiotic. And about 30% of the gonorrhea coming out right now is that. That was in 2013. So the way that CDC is looking at this is that this is a global problem and it requires global treatment. And we see certain areas that are struggling more with gonorrhea than other areas are. And it basically has to do with their mobility of their population and also the access to care and some of the cultural issues that might be there that prevent them from getting treatment. Some of the areas that we're seeing some of the most problems with this is actually in our Mongolia, China areas right now. Pathophysiology for this one is it is the Neisseria gonorrhoeae. It's a gram-negative Diplococcus bacteria. So it is a bacteria that we have here. It does target the cervix and the male urethra, but it can spread to other organs, and it can cause sterility. It's transmitted during oral, anal, or vaginal sex, and it can transmit to the baby during childbirth with eye infections. And this is why when you go to, the baby's been delivered, what do we put in their eyes? Right away. So we're treating that patient, that child, immediately to prevent any kind of problems with gonorrhea being transmitted to them. This particular bacteria also is frequently co-infected with chlamydia. They seem to like each other. Clinical manifestations. Oh, and let's see, what did I write down here? You'll see the rates of gonorrhea. That was 2009. You can see how, when we look at this here, the age ranges, here we are, really at that 20 to 24 age range seems to be one of the highest population here happening. Women more so than men. And why is it that women have it more than men? Because the men are probably the ones that are giving it to the women, but they're not recognizing it. And so they're not getting treatment. Okay, let's look at the clinical signs and symptoms. Let's look at women first. Well, the reality is that usually there are no symptoms. So this is what causes problems for us as women. But as the gonorrhea progresses, you will see PID, pelvic inflammatory disease. Definition, this is an infection in the lower abdomen. What happens is the bacteria moves into the ovaries and the fallopian tubes and the surrounding area, and it scars the tube and blocks it permanently. And this results in infertility, or it can result in an ectopic pregnancy. Have you guys already studied ectopic pregnancy? Okay, good. So this is when that ovary it goes to implant itself down in the uterus, but it can't. So it implants itself in the tube or in the abdomen, and now it ruptures because it can only grow so much. And then we end up with a emergency situation. This patient can bleed out on you. Okay. So this is definitely a problem for our patients. Clinical signs and symptoms, foul-smelling vaginal discharge, dysuria, lower abdominal pain. But the reality is that the symptoms have such a wide variation between patients that it makes diagnosis kind of difficult. So nowadays the policy is that if the patient comes in, the woman comes in with any kind of complaint of cervical, tubal, or uterine tenderness, they just go ahead and treat it because it's not worth it to look this up. Now, when I was working in the emergency room, we had what we called the PID shuffle. And it was pretty reliable that the patient would walk in like this. PID shuffle. Can't see that on Camtasia, so glad. Anyways, but nowadays they are treating, if there's any tenderness, okay? Now, an ultrasound may show enlarged fallopian tubes, and they might show an abscess here, but not necessarily. So just always treat rather than not. Treatment for this is going to be, they may actually need an IV antibiotic combined with a IM medication. And they should start to improve within 72 hours. If they don't, then they need to be reevaluated. Men, the clinical manifestations, again, no symptoms. But as it progresses, they will have a urethral discharge, a milky discharge that actually comes out on their penis. They will have dysuria. They will have itching. They can end up with acute prostatitis and epididymitis. So this is infection, inflammation of their prostate or their edemus. I'm close. I'm close enough. Okay. So when we look at these here on the picture, you'll see here's our enlarged prostate up in that upper item. Of course, that's going to cause a lot of problems with being able to urinate and all that. And then this, of course, is down near our testes, near a man's testes, and this will be inflamed, and so you'll see a swollen scrotum. Both of them very uncomfortable and very obvious to a guy, right? So real easy for the guy to say, ooh, I better get in. So they'll have also with these dysuria, sexual dysfunction, swollen testes, and they can result, it all can result in sterility. The treatment for this, for in general, for all of our patients for gonorrhea, the one before that I talked to you about was the treatment for PID. This one is the treatment for gonorrhea. Single dose antibiotic, they are saying ceftriaxone. and erythromycin. Actually, I did not update this one piece of information here, but originally they were saying single dose. It is no longer. They have now moved on to, they feel that we should have 2 antibiotics for this patient now. And they don't always use the azithromycin. They might come in with doxycycline. And I'm not going to test you on these because they change regularly, okay? But you do need to know that there is an antibiotic that should be given for these patients. And actually, I already told you about that. One of the problems that we're having is people in the Asian area, continent, is where we're having an increase in the gonorrhea. And then, of course, those resistant strains are coming to us because now we have such a global community and travel. Yes?
So for the women, one manifestation of the gonorrhea is the PID. So you would treat the PID as well as the gonorrhea?
Yes.
Okay, so you would take both of those.
Right. Well, and in general, when the patients come in, whether they're male or female, and you know that they have been exposed to gonorrhea and have gonorrhea, then you're going to treat them with those antibiotics. But if the female goes and has the PID, then you've got another layer of infection that you have to deal with. And so they might be able to combine them or not. All right, pathophysiology. Let's talk about syphilis. Syphilis is been decreased in the first time in 10 years. Yay! Except for black men and men having sex with men. So those two groups are still having an incidence of syphilis, but for the rest of the population, there is finally a decrease in syphilis. The pathophysiology, this is a spirochete, the Treponema pallidum. It becomes a systemic disease very quickly. It spreads through the blood and the lymphatics, and it can invade into any organ or tissue. It's transmitted during oral, anal, or vaginal sex. It can also be transmitted to the baby in pregnancy, and it can also be transmitted sore to sore. So this is a skin-to-skin issue that we can have a problem. So at one stage, when they have sores on their hands and I have an open cut on my hand, we can transmit this disease. Didn't want to hear that, did you? Okay. So let's look at some of the things here. Let's look at one more thing that I wanted to talk about back here on pathophysiology is the effect on the baby. It does affect the baby's birth weight. It does cause them more premature births. It also is a higher incidence of stillborn. After delivery, if the child is not treated, say that again. After delivery, if the mother is untreated, the baby can have cataracts, deafness, and seizures. So this is something that during the pregnancy, if we know the woman has syphilis, we need to be treating actively the mother. Okay, clinical manifestations are next. Oh, and let's see, down here you'll see our incidence on our graphs. You can see the men having sex with men are having much more of an incidence here, whereas we'll see our black population also is having more of an incidence of syphilis. And that was back in 2009. Okay, clinical manifestations. This is a very interesting progression of a disease, and this disease has been with us a long time. Many of you that might be people that like to read your different historical novels, you'll hear about different people that have syphilis. This has been around a long time. So let's look at the different stages. There are defined 3 stages, although if you consider the latent a 4th stage, there's really 4 stages. This particular disease can take anywhere from 5 to 20 years to evolve. So let's look at the first stage. Primary stage, this is typically they'll have symptoms in about 21 days after exposure. It can be anywhere from 10 days to 90 days after exposure, but the average is 21. What ends up happening is the bacteria reproduces in the epithelial lining and produces what is called a chancre. And you'll see the chancre there. It is the first sign. It has an exudate that's highly infectious, but it's not painful. It is weepy, so be sure to always put on gloves when you touch any kind of wound. And it can occur anywhere on the body pretty much, but predominantly the most common areas that we see it are the lips, the mouth, the vagina, the penis, the scrotum, and the anus. We can see it in those areas. The duration that this can happen is anywhere from 3 to 6 weeks, and 3 weeks is the average. And that's a really classic, obvious symptom. Secondary stage is it spreads to all the organs. And what happens is we get a skin rash. Do you see that rash down on that person's hands? It's usually on the palms or on the soles of the feet, and it's not itchy. But it is infectious. So we need to be very careful about wearing gloves and being sure to prevent any skin-to-skin transfer. I told you about the time I got scabies? No? Okay. So this kid comes into the nursing office and he's got a rash behind his knees. Just a kind of vague red rash. Not real specific. You know, scabies is usually pretty specific. You see the lines, you know. I was a relatively new school nurse and didn't really know how. And these skin infections and skin problems are not always so clear. So I decided to touch it with my hands. So I touched it and looked at it and all. I just couldn't decide what it was. And I think what I said was, you need to see your mom, let's call your mom and have your mom take you and have the doctor look at it. I then went and did this and scratched my chest. I then ended up with scabies. It was not pretty. It wasn't really ugly, but it's so annoying. You scratch yourself to death. I'm almost scratching myself just because thinking about it. So I scratched myself, and finally I went into the doc. Well, it wasn't finally. I went in pretty fast. Went into the doctor, and you know, it's a really simple solution. It's a 24-hour shower. It's really, I mean, you just put the stuff on you, and wait 24 hours and wash it off. So it's pretty easy, but it just really made me realize, gloves, gloves, gloves. Whenever you touch anything you're not sure of, you know, gloves. Okay, so always put on gloves. So it's amazing that we do as well as we do, actually. I mean, when you think about my whole career and how many times I've actually gotten diseases, that's probably the one time that I've gotten it. I didn't get the shingles that everybody else in the hospital got. I don't know how I avoided that, but everybody else did. They had to close a whole floor because everybody got shingles from this one patient, so. Yeah. Okay, let's look at this. So secondary, we have the skin rash, can have the skin-to-skin thing. We have systemic symptoms that are going to occur with this patient at this point because it's spread throughout their body. They have malaise. They will have regional adenopathy. Their lymph nodes will be enlarged. And this stage can actually run from 1 to 2 years. Next stage. Well, this is not really a stage, is the latent stage. It's not a stage, but syphilis is still present in the body, but there are no symptoms. And at this point in time, it's only infectious to the fetus. So we could have a woman go through the first and second stages, end up pregnant and not realize she has syphilis, and that's why it's really important that we do all that screening as a woman comes in through pregnancy to see if they have any of the different types of STDs or infections that can transfer to a baby. Tertiary is the last, third stage. 15% of untreated will progress to this stage. Most people do get treatment by this stage, but some will not. They'll progress to this stage. And what ends up happening is we have this destruction of the skin, bone, and soft tissue, and it's known as a guma. The guma is actually a hypersensitivity reaction to the bacteria and ends up with the skin or bone or soft tissue being destroyed. And there's a very good example there. If you ever read any of the historical novels, they'll talk about someone losing their nose and things like that. So also, not only will they have this obvious sign, but they also will have cardiac and neurological symptoms. They'll have difficulty walking. They might even have paralysis and dementia. And ultimately, they end up with death. The treatment for this particular disease is a single dose of antibiotics still. This is where they give penicillin, G, 2.4 million units IM for all the stages. So no matter whether you're in first, second, or third stage, that's going to be the treatment. We are going to, of course, treat the patient and the partner, and of course, what are we going to do? Follow-up. Now, what is the recommended amount of days for these patients to come back for follow-up? Any of our patients is 90 days. So you need to remember, they need to come back in 90 days. Yes?
So is the only antibiotic penicillin? Because what if people have like allergic?
No, they can use this one of the substitutes for that. Yes. Yeah. Good question. Now, yeah, because I'm allergic to penicillin. Cure if syphilis is under 1 year. So if we catch it within the first year, we can give a complete cure. But if we catch it, let's say, in the tertiary stage or in the secondary stage, and it's after a year, whatever damage that has occurred from this bacteria is going to stay. Okay? But we can resolve the disease. We just can't push back time. We cannot make it go away completely. Okay? So under 1 year, we can cure it completely, but does not repair damage already done. One of the problems that we have to worry about with treatment for these patients is the what we call the JH reaction, or the Jarisch-Herxmeyer reaction. The JH reaction occurs when large quantities of toxins are released into the body as the spirochetes die during antibiotic treatment. So I give you the IM injection. The spirochetes die. The toxins released from the spirochete now can cause this JH reaction. Now, it doesn't happen to everyone, but it can. It can happen acutely, or it can happen gradually, but it usually occurs in the first 24 hours after treatment. Most of the time, it is just where the patient has like a joints are aching, or they have a lump at the site of the injection. But some patients can go into anaphylactic shock, and they would have to be treated for that with epinephrine and symptomatic treatment of whatever is showing at that moment. So the JH reaction is a reality. It can happen. So when we give that injection, we need to be watching and informing our patient and making sure they come back if they're having any problems. This disease is reportable. Okay? Gonorrhea is reportable. Did I say gonorrhea? I apologize. Syphilis. Thank you. But gonorrhea is too. Okay. Chlamydia. Chlamydia, the incidence of this is the most frequently reported STD to the CDC. Now remember, we don't have all of our disease being reported, but of the ones that are being reported, this is the most frequently reported. Prevalence of this one is under the age of 25. It is increasing over the last 20 years, and at this point in time they say 1 in 15 sexually active females will have it in the age group of 14 to 19. So our adolescent females, about 1 to 15 are having, will be showing this. Pathophysiology, this is a bacteria that actually acts like a virus. God, that's got to be the worst thing. It's called Chlamydia trachomatis. It reproduces within the host cell. That kind of reminds me of HIV, how it does that as well. It destroys the cell and then it starts to cycle again. And what ends up happening is there's this inflammatory reaction and there is scarring of the tissue. And you can see here on our graph, if you go over the times here, we have 1950 to 2007. We have all different diseases here. We have our syphilis, we have our gonorrhea, syphilis. Wait, we don't even have chlamydia here, do we? So, like you can see here, when I was in nursing school, we didn't even have chlamydia. So here is chlamydia starting up in the 80s, and wow, it's just spiraling up, isn't it? So that is why we are so concerned about chlamydia right now. And of course here we see certainly the risk is among our female teenage girls. Clinical manifestations for this disease. One of the things is that I don't have listed here on one of my slides, but I added in here, is the effect on the baby. It can be spread to the baby during childbirth. And what we'll see for these babies is eye infections, pneumonia, and then also preterm delivery is also a high risk. For our female patients, it invades the cervix. It causes pain and discharge and dysuria. But the reality is that 4 out of 5 will have no symptoms. 4 out of 5. 80% of our female patients will have no symptoms. And that's why this little thing here, no signs, no symptoms, no babies if left untreated, because the big risk here, the complication that we have to worry about with these patients is that it may get permanent damage to their pelvis, get PID and infertility. And this is the leading cause, chlamydia is the leading cause of PID. Men, the symptoms that they have, it invades their urethra, so they end up with dysuria, a white discharge, swollen testicles. About 50% of them will have no symptoms as well, though. And complications, though, in the men are rare. So even though they have the disease, they're not having any problems with it, and that's why it's so easy to keep on transferring this on to other females. But now, as far as if a person is engaging in rectal sex, it can also infect the rectum and cause proctitis, so inflammation of the rectum. Treatment for this particular disease is still remains a single-dose antibiotic. Azithromycin is the one that they like right now, and they recommend that the patient abstain from sex for 7 days. It is common for reinfections to occur, and so they do encourage coming back in how long? 90 days. Come back and make sure that it's gone. Herpes is our next one. Now, we have no data on herpes from the CDC because this is not a reportable disease, okay? It's also known as genital herpes. The incidence of this is 16% for the ages 14 to 49, and of that group, 1 out of 6 have herpes type 2. We're going to be talking about the 2 different types. Most common, this is more common in women than in men. Let's look at the pathophysiology. We have 2 different viruses here. We have herpes simplex virus number 1 and number 2. What happens is the virus is going to invade the dermis and reproduces, leading to cell destruction and vesicle formation. And this is classically what you see is the vesicles. Do you all remember what a vesicle is? Little tiny little blisters. Okay. Good to remember what your papule, macule, vesicle, those things before you go into NCLEX. Okay. Okay. So what ends up happening is this virus spreads to the sensory nerves and remains dormant until activated. That really reminds me of the chickenpox virus. And what is the chickenpox virus? Herpes what? Zoster. So these run in similar ways. With chickenpox, we get it along the dermatomes, we'll get it along the sensory nerves, and it stays dormant, and that's where it can come and give us shingles later, okay? Well, this is herpes simplex, and this is an STD, however, and it is going to go into our sensory nerves, and it can stay dormant as well, and that's why when we start looking at the problems that our patients have, it makes sense that it comes and goes. So it spreads to the sensory nerves. It remains dormant until reactivated. The herpes sores will come and go, but the virus is always in the body, okay? And what it does is it does have these vesicles, or these little tiny blisters that occur, and when they break, they shed the virus. So that's where they can then transmit the disease. It is a recurrent disease. It is transmitted by, looks like I must be on a different page, huh? Yeah, here's our different page. The blisters shed the virus, and by transmission, it is transmitted by men to women is the most likely transference. But any direct contact with infected skin or sores can allow it to be passed. It can actually even be passed without sores. So it used to be believed that unless let's say a woman has genital herpes and herpes type 2, and there are blisters there, then they are obviously active and could infect someone else. But they have found now that even when there are no sores there, that there is still some virus that's being shed, and so you cannot determine that is a for sure. So it can be passed without the sores, and also it can be spread oral and genital sex. So we're looking at here, we have herpes type 1, which is typically the oral, herpes type 2, which is typically the genital. And when I first started teaching this content, probably about 12 years ago, we could literally say that 1 did not become 2 and 2 did not become 1, and that you couldn't, just because you had a cold sore, which is herpes type 1, didn't mean you were going to give someone problems. However, over the decade, we have now seen that, yes, if you have oral sex, you can transfer herpes 1 to the genitalia, and you can transmit herpes 2 to the mouth. So there is no guarantees anymore. Do we see it happening very often when you consider that 95% of the population has herpes type 1, get the cold sores? It's very rare. Most people do get it or have had it at once in their life. When you consider that, then you say to yourself, well, then why is not everyone having problems? And they aren't. So it's amazing how the body does seem to prevent a lot of this. But certainly, we'll talk about what we can do here. But one of the things that we also need to talk about at this point is the effect on the baby. If the mother has this disease, it can cause miscarriage, it can cause premature delivery, and it can cause neonatal herpes. We need to treat the mother with antivirals from the 36th week on to delivery. And if the woman is in the middle of having active symptoms, then we need to do a C-section. Clinical manifestations, next page. Oh, here's some pictures of our different, the vesicles, how they look. Clinical manifestations, they usually occur within 2 weeks of exposure. However, most do not have sores, and most are mild and go untreated. So that's good news. Some of the symptoms they might have, flu symptoms, tingling, itching before the sores occur, painful red papules, those are those little red bumps that then progress to painful blisters that last days to weeks, and then usually they heal in about 2 to 4 weeks. The blisters will break and create painful ulcers. The broken skin places the person at very high risk for other STDs, especially our HIV. The good news about this, because you're all going like, oh my God. The good thing about this is that the symptoms become less and less with each episode. So the worst episode is the first episode, and then it gets less and less with each year. But a person could have outbreaks as much as 4 to 5 times a year when they have severe cases. There are also patients that have chronic asymptomatic STDs. So there's about 1 in 4 that will have very mild symptoms or no symptoms with this. So it's like, wow, how do you determine who has it and who doesn't have it? Well, what it comes down to is you have to do all those preventions in the very beginning that we talked about, right? You have to maintain all those things to prevent you from getting exposed to an STD. One of the things that, a story that I have is I had a friend that when I was working as a school nurse that I worked with that had came down with this type 2 herpes and had the genital herpes very badly, a bad case of it. And of course she found out that her husband was cheating on her when she came down with this genital herpes. So then we had all this, not only dealing with the physical changes, the problems of a lifelong disease, because this is a lifelong disease, it's incurable, that, but also having to deal with her husband having been the one that brought it home to her, and then of course going through the divorce. She was a very angry woman, very, very, very angry. And I went through probably a couple of years listening to her anger, and of course every time this would reoccur and have an outbreak, of course that would just make it worse. But I'm happy to say that the antivirals that she ended up taking did diminish the symptoms. She put into place some of the things we're going to talk about here to help diminish the symptoms. And it got better and better with each year. And she did dump that husband, and she got a new husband who was a great guy. So all ended well. But let's talk about that treatment. Treatment cannot be cured, but it can be controlled, yes. I can't tell you that. I know usually when there's a lesion, they do the scraping. So there must be a lab value. I will find out for you though, because I don't have it right off the top of my head. That's right. And I'll look at that one too. So pregnancy, does anyone know that answer? Yes.
For herpes, it will become in the pap. Most of the time.
It'll show in the pap. That makes sense. Where do you work?
OB-GYN.
Yeah. So that's why you've been nodding at me. So I was like, you've been dealing with these things. So yeah. So pap, that makes sense that you would see it there.
You have to have an outbreak to do that picture. If it's not an outbreak, you can't.
You can't get the scrapings at all. Yeah. Oh yeah. Because so when they go in to check the cervix and everything, that's when they could do their pap right then.
So how about with donating blood? Does that get through the screening?
It isn't a blood transfer disease. So the only ones we have to worry about that is our HIV and hepatitis B. Those are blood transfers. These are skin to skin or sexually transferred through the vesicle being there, the disease being there. Yes, because I do have people that I know that have had the disease, and then you have to have that conversation with your partner that you have this disease and this is how you control it, and have to go through that discussion. Yes. This can be skin to skin, yes.
Do like a sperm donation and do some sort of clear it out?
So you're only going to have sex through sperm donation? I don't think so. I don't think so, yes. Ah. Make sure you didn't have any of those. Okay. So there she gave you your answer about that. Thank you. Thank you, Google. We love that. So we do. There is a lab test. Thank you. Okay. The other thing going on here, let's see, I talked about the effect on the, okay, we talked about the woman and the blisters and the outbreak, okay, and the treatment. Okay, so it cannot be cured, but it can be controlled. Medications, which are antivirals, because this is a viral disease, speed the healing, and they do prevent outbreaks. Acyclovir is the drug of choice here that they'll take 3 times a day for about 7 to 10 days after the first outbreak, and then they'll take it twice a day after that. And then I just have found that talking to people that have this disease, that they eventually get farther and farther away and don't have to take it as aggressively. But in the beginning of the disease, they are taking these antivirals pretty aggressively to try and control the outbreaks and trying to control the symptoms. But as they get farther, a year or 2 out, I see it less and less. The daily antivirals will suppress the symptoms, and it will also decrease the transmission to your partner. And so this is what it's also being used for, is to help with diminishing the risk for transmission. Nursing focus. Well, nursing focus is to promote comfort. And also we want to do some client teaching. So client teaching, we want them to avoid sex during the prodromal symptoms. That's where they start to get some kind of a warning symptom, where there's burning and itching at the site where the lesions will occur. We want them to try and minimize the amount of outbreaks, and the way that they can do that is by diminishing the amount of stress, fatigue. Remember, outbreaks can be triggered by stress, okay? And they can also be triggered by fatigue. Now, this is how do you avoid stress and how do you avoid fatigue, but you do need to try and do that. Menstruation is also another one that can trigger an outbreak, as well as lack of sleep and genital friction. So some of these you can minimize. You certainly can try to be proactive and try and maintain your life as balanced as possible. Others, I think that you have to just really do the best that you can. Okay. HPV is another disease that we're going to look at today. This gives us no data from CDC, although they do have lots of information in there. It's just nothing that they're collecting nationally. Incidence, they say this is the most common STD. Of all the STDs, even though they're not reporting it, it's the most common one. As of May 2014, so that's pretty current information that I have here, they say that 69% of all sexually active people have had HPV, human papillovirus. Everyone gets one type, is what they're saying. But this is the good news, 90% of the patients that get this, 90% of us, their immune system clears it within 2 years. Pretty cool. Most don't even know that they ever had it. Okay? So pathophysiology of this one, the HPV has many different types and subtypes. The last study I just saw said 120 types. Okay? And not all of them cause disease. And you can get more than one type. There's just a few of them that cause the problems. Okay? So that's the ones we're going to look at. They change normal cell growth. They can affect the genitals, the mouth, and the throat. That's one thing we're finding out now, that you can also get it in your mouth, and you can end up with actually oral cancer secondary to it. So we'll talk about that in a minute. And they believe that the way that it works is that it weakens the immune system. The effect on the baby is that it ends up with actually being a very low risk to the baby, and the baby can clear this virus on their own. Diagnostic tests, there's some new diagnostic tests coming out. Normally I don't talk about diagnostic tests, but this new one just came out. It's called COBAS, C-O-B-A-S. It's called COBAS HBV, and they feel that it is going to actually be a better indicator of cervical cancer than a PAP. So PAP is what we've been using for cervical cancer, but we all know that cervical cancer is predominantly, almost always, an HPV virus. And so if we can be detecting the HPV virus early, then we can detect for cervical cancer. So they're talking about that. It'll be interesting to see if it really happens, because remember I talked about the PSA. We thought that was going to be a great one to tell us about prostate cancer. Over a period of time we realized it wasn't going to be as great as we thought it was going to be. So let's see what happens with that COBAS. Okay. Clinical manifestations. Many do not have symptoms. They believe that 80% of women over 50 have had it with and without symptoms. So this is one of those ones that it looks like our general population has had this disease. Most of us don't have symptoms from it. Some of the symptoms, though, that can happen is genital warts. This occurs within months of getting HPV, and there is an example over on the right-hand. Oops, sorry. Let's go back. There's an example of it over on the on the right of the cauliflower sort of warts. They are painless. They look like cauliflower, one of my favorite vegetables. Now it's not. Cauliflower-like growths. And it typically is in the genitalia, but we also have seen it in the mouth, on the tongue. And other things that we also see with this is the cervical cancer. Actually, that's the one we are the most worried about. But it also can be rectal. It can be transmitted through the rectum, but not as commonly. We don't see it. It takes years to decades to develop this type of cervical cancer, and it's usually caused by types 16 and 18. So I told you we have all these different types, but it's the 16 and the 18 that we are worried about that causes the cervical cancer. The symptoms only come after the disease has progressed. And PAPs are definitely one that we have been using in the past to screen for abnormal cells to be able to see whether the patient, the woman, is developing cervical cancer. Now we've got this other one coming out. Let's see how that works. We also have a risk of oropharyngeal cancer. This is actually new over the last decade that I've seen. We're seeing that they're seeing about 7% of this with the patients with this disease. Men are 3 times more likely than women, and they're still kind of in the middle of trying to figure out what this is, and if all the oral cancers we've seen in the past that aren't caused by smoking and tobacco use and all those could be caused by this HPV. So that's why now you see when you go in to your dentist, they will check all your mouth. Now they're checking for the oral cancer, and they are thinking in terms of the tobacco use and everything, but they're saying when I talk to them that they see more of the tobacco and other causes up in the upper part of the mouth, but the HPV they're seeing back farther and towards the soft palate. So they're seeing it in a different location. So that's kind of interesting. Treatment for this, well, for the genital warts, we can utilize a topical agent or surgery. The most common being this particular medication here, Aldara, is one of the most common ones that we use. 5% cream is used to help with genital warts. Another one is that another treatment policy is the colposcopy. This is where you can see here they're coming in behind the cervix there, and they're going to go ahead and remove whatever part is got part of the abnormal tissue. What they basically are saying right now in the literature is that if they have a positive colbos, they will go right ahead and in with the colposcopy and remove that part of the tissue that is affected so that it doesn't progress on into life-threatening cervical cancer. Another treatment recommendation is for our vaccines. They are recommended for 11 to 12-year-old boys and girls. We try to usually make sure that they get it as they come in for their 6th grade, so when they come into middle school, they have to bring in their immunizations that show that they've done the HPV. It has been actually available for like 5 years. When it first came out, it was very controversial. I'm not hearing as much controversy nowadays as I did hear when it first came out. The particular vaccine is recommended, I said, for the 11 and 12-year-old, but they can give it anywhere from the ages of 9 to 26. And but I know that my daughter, I think she was like 24, and I said, you need to go in and get that done. And they really weren't encouraging giving it to older women or people. They were really encouraging going for that person that they knew for sure had never been exposed to HPV. And so they want to protect them against the cervical cancers. It actually, the Gardasil, which is one of the most common of the vaccines, protects them against 70% protection against the cervical cancer type 11 and 90% protection against the genital warts, which is type 16. And so they have to come in and get 3 doses. It's the same as like what we have with the with the hepatitis B, where they come in, have the first dose, then a month later they have the second dose, and then 6 months later they have the 3rd dose. Yes.
How long does this vaccine work? Do you get it at covered through?
Well, and they, they used to say that all of our vaccines lasted forever, but we are finding out now as the baby boomers are aging, we're seeing that the diphtheria one did not last. We needed to get a booster. We know that hepatitis B, we have to have boosters every 10 years. Now we're finding out with the shingles, the herpes zoster, we need a booster after age 60. So all of them, they're kind of finding out as it evolves that when they need the booster. So it'll be interesting to see when the booster needs to come for this one. I don't know. I haven't heard any literature on that yet. So, but yeah, we've only had it for 5 years right now, so we'll see. Okay, so actually, and something that was interesting as I was looking through the information about this vaccine, we're getting away from people having being upset about the controversy. A lot of people were not happy about this particular vaccine being offered to young children, believing that it was like sanctioning early sex, and they didn't want to go that direction. But it seems that the population seems to be changing a little bit more and now looking at it as just protecting their children from any diseases that might come as they get older. So have you guys heard anything from people as you were, especially if you have young children, you probably are hearing some of this. Anybody want to share? Nothing exciting, hey? Okay, and then one thing that they did say that part of the problem is that they're finding that there's a real non-compliance. Now, it's always difficult when we have to do 3 vaccines, right? Well, you know that from you guys had to get your 3 hepatitis Bs, right? You really have to stay on top of it. It's easy for time to go by and you go, what? What do you mean 6 months has gone by? So they say that of the people that they're having doing the vaccines, they get 40% compliance. 40% of all the kids are doing this on their first dose. Okay, so we get 40% of the population getting the first dose. But only of that group, only 50% are actually completing the survey. So we probably only have 20% of the population that's actually being protected. They say that the real key is the doctor recommending it, and education, of course, is key. So we are done with that.